While we know already quite a lot about commissioning as an idea, what it's meant to achieve, some of the basic principles by which it's meant to work, that separation of the planning and purchasing function from the job of actually delivering healthcare services, with the idea that it'll allow the opportunity for setting standards, for competition between providers and so forth. There's been much less work done about what actually goes on the ground, what we like to call the nitty-gritty of commissioning, how it's played out in the real world. So in other words, when you have someone whose job is a commissioner of healthcare, have been for the past few years, primarily the people working for primary care trusts, what do they do? What is their day-to-day work? How do they go about bringing improvements to the delivery of healthcare at local level? That's what we were looking at. So from our point of view, I think what seemed the most relevant way to try and judge the effectiveness of commissioners in the context of long-term conditions was in relation to shifting models of care, because that was most clearly where their role had a direct impact. Because you could say with the clinical outcomes and the efficiency and so on, how much is to do with what the commissioners are doing and how much is to do with what the providers are doing anyway, or patients are doing for themselves in the case of clinical outcomes. So in the context of long-term conditions, looking forward to see how effective commissioning can be at bringing in those new models of care, bringing them in sustainably, but at the same time having a plan for monitoring and reviewing whether they're really working, is, I think, where you need to centre the attention on judging how effective that commissioning role is. It's going to be very interesting, I think, in the new world after April. One thing we already saw, because the process has started to get underway while we were still doing our fieldwork, is the loss of staff with a lot of experience and a lot of connections. And since so much of what we were observing was relational, it was about people working with each other, knowing what was going on, knowing each other within the local area, a loss of key people may have quite an interesting impact on what happens in the future. Another thing which is going to be interesting to follow is what happens when you have far fewer staff getting involved in doing commissioning, because the resources available to the new CCGs to spend on the commissioning process itself are much smaller than the budgets that were funding PCTs. And since we already saw what a lot of work was going into developing new service models and bringing them in and supporting implementation, there's going to be a lot less capacity to do that. And what that means for the new CCGs is they're going to have to think very smartly about what aspects of that relational work, that developmental work, actually they can do without or transfer over to providers, who of course may also be GPs, part of the landscape of provision. And also be quite hard-headed, because of course there is a risk with any developmental work and bringing organisations together and so on, that maybe some of the time isn't used as efficiently as it could be, and that you need to be a bit more strategic about saying, we're going to get this done by this date, and having cut-offs and then moving on to the next stage. So maybe it'll be a push to help that to happen. There's also going to be some quite interesting things going on, I think, about the sort of dual nature of the role of GPs as commissioners and providers of care, which is a situation which we've had to a small extent with the practice-based commissioning previously, but this is taking it to a whole new level.